So I'll be speaking on behalf of all of the authors, most of which are in this room. I'm Juan Frias, and I'm the Chief Medical Officer of BMF Fusion. And I'll be talking about BMF-219, which is a covalent menin inhibitor that is being investigated to reestablish beta cell function and beta cells, I should say, and beta cell function and long-term glycemic control. Here are my disclosures, and I am now an employee of BMF Fusion. So by way of background, menin is a scaffold protein, and when it partners with its binding partners, it has many functions, including regulation of gene transcription and cellular signaling. At the level of the beta cell, it actually plays an important role in glycemic control, whereby inhibition of menin activity enhances beta cell proliferation and function. So BMF-219, as I mentioned, is an oral covalent menin inhibitor. It's in clinical development now for both type 2 and type 1 diabetes. In preclinical models of diabetes, short-term treatment has been shown to result in durable glycemic control. And at the American Diabetes Association this year in San Diego, we presented initial data from our multiple ascending dose study. And this was 2 arms, 100 milligrams with and without food, patients treated for 4 weeks. And at that point, we looked at 12-week data, so 8 weeks after cessation of therapy, and saw improved glycemic control and saw that the compound was safe and generally well tolerated. So what I'm going to do in this talk is talk about some work that we've recently done or has recently been done in human donor islet microtissues, and then also give longer term data, so 26-week data now, of those 2 arms of the multiple ascending dose study. So here we see the study design of the ex vivo human islet microtissue studies. These are cadaver-derived human islets from people without diabetes. The islets are dissociated and then reaggregated. And we studied actually BMF-219, Harmine as an active control, and also a vehicle control for 1, 2, 3 weeks, and then also a study for 2 weeks with a 1-week washout. And these studies were done under 2 conditions: standard conditions of 5.5 millimolar, or about 100 milligrams per deciliter, and under high glucose conditions, so 8 millimolar, or about 145 milligrams per deciliter. And we looked at a number of things. I'm going to talk about beta cell proliferation during these studies and also beta cell insulin content. So here we see the beta cell proliferation, and on the left you see under standard glucose conditions, so the 5.5 millimolar, on the right under high glucose. And what I'm going to show is proliferating beta cells as a fraction of total beta cells, so the fraction of proliferating beta cells. And what's shown here, and I would probably direct your attention to the high glucose, is the fraction of proliferating beta cells with the solvent. And this is known that under high glucose conditions, there is an increase in glucose-stimulated beta cell proliferation. So if we look now in green with BMF-219 and in blue with Harmine, you can see that after 14 days at high glucose conditions, there's an increase in beta cell proliferation. So the fraction of proliferating beta cells has increased. There's variability between these microtissues depending on the donor, but you could see at 21 days, although it's still above the solvent or the control, there is lower proliferation, which indicates that these cells do not continue to proliferate, which is something you want to see. And as important is after the 14 days and the 1 week of washout, you've pretty much returned to normal. So what we see here is that the proliferation observed is observed only under elevated glucose conditions, so it is glucose dependent, and with continuous drug exposure. So that's donor 1. If we look at donor 2, again, under the high glucose conditions, you see increased proliferation, even with the solvent or the control. And we see, and in this experiment, we looked at different doses of BMF-219. You see some dose dependency with respect to the fraction of proliferating beta cells, but again, seeing the increased proliferation that is glucose dependent here as well. If we look now at the beta cell insulin content, and this is looking at the first donor, and I would concentrate again on the right-hand side under high glucose conditions, consistent with the increase in beta cell proliferation. You also have an increase in beta cell insulin content, and that's seen, we saw that with donor 1, as well as with donor 2, some dose dependency here as well. We've also, and this is in native human islets, done some preliminary work looking at gene expression. CCNA2 and PBK are genes that are known, or these are proteins known to support beta cell proliferation. And the increase has been seen in menin knockout or knockdown experiments as well. So this is consistent with what's been seen, what we're seeing here with the BMF-219. So I'm going to turn now to the clinical study. So this is a multiple ascending dose study. If you look on the left here, the eligibility criteria, these are adults with type 2 diabetes, duration of diabetes less than 15 years, poorly controlled at baseline with an A1C between 7 and 10%. And these patients were either treated with lifestyle alone or up to 3 anti-diabetic agents. And there could be any agent other than an insulin secretagogue or insulin. And what you see on your right are the multiple doses we've studied. I'm going to concentrate on the 100 milligram dose once daily orally for 4 weeks. And we had 10 patients in each of these cohorts. So 10 patients with food, 10 patients without food, and 2 controls per cohort, or placebo-treated patients, I should say. And again, I'll talk about 4 weeks of treatment and now 22 weeks of therapy or of off treatment, so out to 26 weeks total. The primary objective was safety and tolerability. Secondary objectives, the pharmacodynamics of BMF-219, or kinetics, I'm sorry, and also glycemic parameters, so looking at hemoglobin A1C and CGM parameters as well, and then measures of beta cell function, so HOMA-B, and also stimulated C-peptide. These are the baseline characteristics of the patient. So mean age around 50, duration of diabetes anywhere between 4 and 9 years, depending on the cohort. The mean A1C at baseline around 8%. And the majority of the patients were on monotherapy, metformin monotherapy, but there were a handful of patients, 4 patients, that were treated with either 2 or even 3 oral agents and not well controlled. This shows the pharmacokinetics at day, I should say, 28. So after the 4 weeks of treatment of BMF-219 without food in blue and with food in the orange, you can see greater exposure. This is looking at the area under the curve at the end of the 4 weeks of treatment without food. And in those patients treated without food, we saw a greater pharmacodynamic effect as well. You can see that after 26 weeks, a 0.5% reduction in A1C from baseline and a 0.8% reduction, placebo-controlled reduction. If we look at other key glycemic parameters, again, I mentioned the hemoglobin A1C at the top, the percent of patients with greater than or equal to 1% reduction in hemoglobin A1C out at 26 weeks was 20%. And we did an exploratory analysis looking at those patients who responded, and responders here at 26 weeks were patients who had an A1C reduction of greater than or equal to 0.5% and were not hyperinsulinemic at baseline, so had a HOMA-B less than 200. And you can see on the left, this is the mean change in HOMA-B from baseline to week 26, significantly higher in those patients treated with 219 compared to placebo. And on the right, the percent change in the area under the curve of stimulated C-peptide. And I'm just going to briefly go over 2 case studies. So this is one patient that was treated with 100 milligrams once daily, 45-year-old man with a 9-year history of type 2 diabetes, treated with metformin monotherapy, A1C at baseline 8.4%, and had no tolerability or no issues or no adverse events. And you can see on the left the change in hemoglobin A1C over the 4 weeks, 12 weeks, and 26 weeks of therapy. And again, this is 4 weeks of once daily therapy. The therapy is stopped and the patient's only on metformin throughout the rest of the treatment period. And on your right, you see the CGM in this particular patient over 75% in range of 70 to 180 milligrams per deciliter at week 26. You can see also in this patient a significant increase from baseline at week 26 in HOMA-B and also in stimulated C-peptide secretion. In a second case now, and this is a case actually of a patient treated with 200 milligrams once daily. So for some of the two other cohorts that we had in this study, this is a 29-year-old patient with a 4-year history of type 2 diabetes, very poor control of baseline on metformin and an SGLT2 inhibitor, so an A1C of 9.5%. And we see a very dramatic reduction in hemoglobin A1C after the 4 weeks of treatment with 200 milligrams and then withdrawing the therapy, and also a very nice improvement in time in range with over 90% time in range at week. In this case, it was week 21. And in this patient, also significant increases in HOMA-B and in C-peptide as an indicator of improved beta cell function. With respect to safety and tolerability, 219 was well tolerated and safe. There were no severe or serious adverse events, no drug discontinuations or modifications, no symptomatic or clinically significant hypoglycemia. So again, the proliferation occurs in the face of hyperglycemia only, and all patients completed 4 weeks of dosing and were followed for the full 26 weeks. So in summary, in the ex vivo cultured human islet microtissue work, BMF-219 enhanced beta cell proliferation, increased beta cell insulin content, and did so in a glucose-dependent manner. In patients with type 2 diabetes who were treated for 4 weeks with 100 milligrams once daily of 219, there were clinically meaningful improvements in glycemic control out to week 26 or 22 weeks after discontinuation of the drug. And these combined results support BMF-219's key mechanism of action, which is beta cell proliferation, and support the novel disease-modifying potential of short-term BMF-219 therapy. Again, these doses of 100 milligrams, I have to remind you, were the first doses that we studied in patients with type 2 diabetes. In patients treated with 200 milligrams once daily, and these are data that we're going to go into in much greater detail at the ATTD meeting in Florence in March, we did see that at the end of 26 weeks, 40% of participants achieved greater than or equal to a 1% reduction in A1C, which was twofold greater than what I just showed with the 100 milligram dose. And with respect to next steps, we're currently conducting a phase 2 study looking at 8 and 12 weeks of dosing with 100 and 200 milligrams once daily in patients with type 2 diabetes. And we've initiated now a study in patients with type 1 diabetes as well. So thank you very much.